Paul and gang gave me this easy talk that is light enough that it should only take 2 or 3 minutes of this 7-minute period. So just sit back in your chair, relax, and we're going to magic carpet ride here. So that said, this thing is really emerging, or it is welcome to any qualifying trials for CPD, right? There are disclosures, and as we go through this, we're going to touch on some things that you obviously know. Cerebral lesions, the vast majority, 70% noted, but fundamentally we're moving to the point where 100% of these things are there. We know we can collect them right here. We know we can collect them. We know we see them in everything. We have 1.1 million slides and pictures and things on the table to show you that, but you already know that. Where do these things come from? We've got this filter the brains are using, and they come from both arches, ascending and transverse. It comes from the valve, the stenotic valve itself, the device valve, the native heart. We know that in this fashion, the stroke rate has this smorgasbord starting from right to left of what has really been high in the past. I'll show you that later this afternoon. But fundamentally, you'll notice the pink one is actually the Sentinel control arm, which is interesting that it's almost 10%. The brains are adjudicated by neurologists, NPs, and PAs. You can see that blue and SAVR, the core valve family comes down, SAVR and gray comes down. Sapien is moving low, and this is an important issue about where these things are going. Here's the problem. The clinical part of this is on the tip of the iceberg, what we see, the strokes, even the TIAs, and we talk about the fact, well, it cleared in less than 24 hours, less than 12 hours. Well, it was minor, didn't even affect them, or just neurocognitive. And the whole battle is going to be fought down here. You know, we're going to accept some facts about these things, even as the numbers going down, and see where this goes. So unlike everything else, I'll show you the next slide. This is not getting better. Here's 7 years of TVT registry across the top, any stroke, ischemic stroke, across the bottom, hemorrhagic, undetermined, TIAs. This is the one thing that is not getting better. If you look at the small print, upper left is mortality, 400 cases, continues to come down. Vascular continues to come down. Bleeding continues to come down. Stroke has got this now brilliant hornet that is not coming down, and we really haven't conquered this piece yet. So that leads to a little bit of the excitement and discussion of do you or don't you. But just like everything else, strokes are expensive. You know the numbers, and you see that whenever we get to cost. Problem is the TVT registry. Now broad strokes approaching 10 years, salt in the wound. Essentially 5 times the mortality, stroke, no stroke. And what happens to everybody? They don't go home. You already know these things, but whenever you forget to look at it day after day, we don't remember where that is. So we're going to accept some facts. Do these filters take out debris? They sure do. We're going to accept that. Is there a decrease in 30-day mortality risk? It looks like there is. There are a lot of trials that are trying to show that. Here's one example I pulled out, though, the Sentinel trial. And what we get is a p-value of 0.25 when we get to strokes. So we've run into a little trouble as we get into the RCTs and the registries, and the RCTs don't show it as well. This includes Sentinel in the 5 and then a total, and the thing is now being labeled as trends towards reduction. The problem is the p-values never get there, and people are now trying to make leap to conclusion clinical decisions about it. Samir shared with us the fact that in 2018, they did 494 patients, but they put 474 on CPD. They had great results that year as everybody's moving to low mortality, but their stroke rate also moved to 0.2%. So he's making the argument in a 1 to 2% environment, everybody gets one, and we're going to win this battle. The problem is, as we look at the literature and we look at the things that are going to be controlled, things are less certain. The number of new cerebral lesions is really not significant. The 30-day stroke rate is really not significant. 0.22. This is 0.08. Less certain is the 30-day mortality, 0.20, 0.45. So now we're running into trouble proving it, and now we're going to pay for it, all right? And now we're going to pay $3,000 device, add on to your case cost I know most of you are making money because you're in a better reimbursement place than we are, but we certainly have problems depending on where you are. So this is going to become a real issue, and what's the number needed to treat? And the CPDs, while they may be great, they're not perfect either. You know, do you always get it in the right place? Do you catch every emboli? Is it a complete barrier? Some of them designed that way. Is it going to take care of posterior circulation? And don't forget, only 2/3 of the stroke occurs at the time of the procedure, 80% in the first day, but not all of them immediately. So let's cover this real quickly. The ideal embolic device, this is just some ideas that everybody has, but here are my ideas. It's got to be easy to use and deploy. Every time you've had one of these, they bring you one, you look at it. If it's not easy, you're thinking, I'm out. I want to go somewhere else. I don't want to do it. It's got to go first in, last out if it's going to really protect. It's got to protect all the cerebral circulation. And now we have possible total body protection. It's got to be stable with the device, capture all the debris, probably remove all the debris, not restrict cerebral flow, and not add substantial risk or cause a stroke by itself, and it's got to be cost effective. Easy to say, hard to do. So where do we go from here? Here's a cerebral protection Olympic. Let the games begin. If you think venture capital's out there throwing money, they're throwing it in healthcare and they're throwing it in embolic protection devices. So there are a number of them on here. We'll run through some names, but we have several categories. You can break this down multiple ways, but here are deflectors. Here's capture and remove. Here are dual devices, deflection and capture. Here's full body capture and remove coming. So what does this look like? The landscape, this is a little small, but we're going to run through them at speed dating here in just a second. You can look at the red, and fundamentally it gives you how they capture, remove, or deflect the debris. You can see the FDA clearance and CE mark for SENTINEL and TriGuard finishing the second quarter along with the rest of them. Here's the second page of that, and then let's just take them for a spin. Buckle up, we're going to go speed dating with CPDs real quickly and get out of Paul and this panel's way here. Deflectors, Embrella, it's been around forever. Radial or brachial, TriGuard, just finishing the trial, TriGuard 3, everybody that used it, it's a much used device, flips up there, certainly takes care of cerebral. Protembus, 6 French, left radial, simple, quick, complete cerebral protection. Point guard, same thing with adapting to variable arch anatomy and very user-friendly. Capture and remove, you know the SENTINEL device. 2 filters, so is SENTINEL Next Gen going to have 3 filters and catch up with everything for full disclosure. Safe pass, just completed first in man, same thing, capture, great efficiency, capture and remove. Dual, deflection and capture, full body embolic protection. So the Emblok has complete circumferential coverage of the arch protecting cerebral and distal vasculature. We didn't even talk about what happens if you throw this trash down to your kidneys and legs, but this is going to turn out to be an interesting issue if you can get the trials big enough. Emblok, the Next Gen, is this big pillow that's going to cover it both ways and see where it goes with Gen 4. The Emboliner is the same thing, expandable across all the aorta, and you can see the close end of the filter catches the debris and removes it. So back to, and then this is, I think this is the last one I'm going to show. There are 2 or 3 more. They're evolving every day. I couldn't make the slides fast enough as money's being thrown at this. So, but if you look at this, this is full body capture. It's deflecting particles with complete cerebral protection, throws it down here to stop it, captures the particles, renal protection, distal extremity protection. And so that's the picture. Where do we go from here? Well, certainly we don't like the idea of strokes. If I ask each one of you, if you know enough and you understand, do I want a filter or not? I mean, you're having TAVR today. Do you want a filter? I'll tell you, Mac and I said as soon as you saw the first diffusion-weighted MRI, we go, I want a filter. Today, it's a little bit different story. Okay, is that filter going to cause a stroke? Don't really know, but strokes are devastating. So what do they have to do? We kind of hit on it, and here are the challenging pieces for developing technology. It's got to have a good clinical methodology, and somebody's got to figure out which one's going to win of Hertz and Avis between capture and deflect. Clear proof of clinical benefit. And are we talking about the tip of the iceberg? All the iceberg. It's got to have ease of use, as we talked about, and it's got to be efficiently integrated into the case. It's got to have safety of use as well, and have anatomic considerations with full cerebral coverage, possibly full body coverage, and repeating interaction with the TAVR systems, and then finally cost effective. And so I'm going to give you one more piece. in spite of some of the mild predictors, and we didn't really cover those well, the inability to identify patients who are actually going to have the stroke have led to the theory, protection for all strategy. Okay, imagine the associated cost. May be good for certain people, but not good for all, and maybe difficult for healthcare. So the fun part is there's an exponential increase in people throwing money at it and the resources and the development of next-gen devices. So stay tuned. Thank you.